Hello guys, welcome to the Whiteboard Talk. So I'm thinking that you have watched the basics of nephrotic syndrome video so that you will have a better understanding of all these diseases. In this lecture, we will be learning about membranous nephropathy. If you have not watched the video, I'll have a quick overview on this. So coming to basics of nephrotic syndrome, there will be derangement in the glomerular capillary walls results in increased permeability to the plasma proteins. These are the four components of nephrotic syndrome. We have massive proteinuria more than 3.5 grams per day, hypoalbuminemia, generalized edema along with hyperlipidemia as well as lipiduria. These are the reasons. Because of generalized edema, there will be secretion of aldosterone, activation of sympathetic system as well as reduced ANP levels. The patient will have hyperlipidemia because of these causes, that is increased synthesis by the liver, abnormal transport as well as decreased catabolism. The complications of nephrotic syndrome will be increased vulnerability to infections, thrombotic complications as well as renal thrombosis, and these are the causes of nephrotic syndrome. It can be primary glomerular disease as well as on the background of systemic diseases. We'll be going through the lecture with each of the primary glomerular diseases. That is, in this lecture we'll be learning about membranous nephropathy. In the upcoming lectures we'll learn about the minimal chain disease, FSGS, MPGN and IgA nephropathy. These are the systemic diseases that can lead to nephrotic syndrome. Moving on to the membranous nephropathy. In membranous nephropathy, there will be diffuse thickening of the glomerular capillary wall. There will be diffuse thickening of the glomerular capillary wall. There will be diffuse thickening of the glomerular capillary wall. This is due to the accumulation of deposits containing immunoglobulins along the subepithelial side of basement membrane. 75% cases of membranous nephropathy is due to primary disease affecting the glomerulus. 25% of these causes will be secondary. Okay, let's go over the definition properly. In membranous nephropathy, there will be diffuse thickening of the glomerular capillary wall, and this is due to the accumulation of deposits containing the immunoglobulins, which are deposited along the subepithelial side of the basement membrane. 75% of the disease will be primary because of the glomerular capillary wall leakage. 25% of this disease will occur on the background of secondary causes. What will be the etiology of membranous nephropathy? Let's look at etiology of the membranous nephropathy. It can be caused because of drugs. What kind of drugs? Such as penicillamine could be because of ACE inhibitors, ARBs, gold poisoning, as well as NSAIDs. So these all can lead to membranous nephropathy. The second cause, it could be occurring on the background of malignancy of the lung. We have the colon as well as malignant melanoma. It can also occur because of a patient suffering from SLE, that is systemic lupus erythematosus, if a patient has certain types of infections, as well as other autoimmune disorders. Okay, so this will be the main etiology of the membranous nephropathy. Let's go over the quick review on the pathology of membranous nephropathy. Alright, moving on to the pathophysiology of membranous nephropathy. So in this we have two antigens that you need to remember. One is PLA2R, phospholipase A2R receptor. The other one we have is THSD7A. And then we have IgG4 class of immunoglobulins, and it is through this IgG4 mediated complement activation that is C5b to C9 and this is the membrane attack complex, MAC activation. So when this IgG4 mediated complement activation binds with the antigens PLA2R and THSD7A, it leads to antigen antibody complex, and these complexes are deposited in subepithelial. So there is subepithelial deposition, and this is what we see in membranous nephropathy. Moving on to the morphology of membranous nephropathy. Morphology. What we see is uniform diffuse thickening of capillary glomerular walls. So moving on to the morphology, we see uniform diffuse thickening of glomerular capillary walls. Okay. We also see effacement of podocyte foot processes. Effacement of podocyte foot processes. Then we see dome-like spikes by silver stains. Dome-like spikes by silver stains, and this ultimately progresses to segmental sclerosis. This ultimately progresses to segmental sclerosis. This is what you need to remember regarding the morphology of membranous nephropathy. So we see uniform diffuse thickening of the glomerular capillary walls along with effacement of the podocyte foot processes. We see dome-like spikes when we use silver stains, and it ultimately progresses to segmental sclerosis. Moving on to the clinical features of membranous nephropathy. Clinical features. So this disease has an insidious onset. Disease has an insidious onset, and its clinical features are similar to the nephrotic syndrome features. Similar to the nephrotic syndrome features. And what are the clinical features of nephrotic syndrome? As we had just discussed in the previous video, this includes massive proteinuria of more than or equal to 3.5 grams per day, hypoalbuminemia with plasma albumins less than 3 grams per deciliter. The patient will have generalized edema due to sodium and water retention, as well as hypoalbuminemia, as well as hyperlipidemia and lipiduria. Please watch the previous lecture to learn the basics of nephrotic syndrome. So those are the clinical features in membranous nephropathy. The patient will also have mild hypertension. Okay. When it comes to the treatment or simple management, we'll treat the secondary cause. The secondary cause and their clinical features. We'll treat that first. Ultimately, the progression of membranous nephropathy, it will progress to FSGS, that is focal segmental glomerulosclerosis. Ultimately, it will go into ESRD, that is end stage renal disease. So this is all you need to know about the membranous nephropathy. Thank you for watching.